Assalamu alaikum. I'm Dr. Abba Sajjad from Anatomy Department, Sahara Medical College. And today the topic of gross anatomy is fibula. The objectives are to discuss the general features of fibula, its attachments, and in the end, the clinical anatomy of fibula. Fibula is the posterolateral thinner bone of leg. Superiorly here it is attached to tibia on its lateral condyle by a synovial joint forming the superior tibiofibular joint. In the middle the shafts are connected by a syndesmosis made by the interosseous membrane. Inferiorly the two bones are again connected by a syndesmosis, another interosseous ligament, and then fibula lower end completes the rectangular socket for the ankle joint. This bone is not for the weight bearing of lower limb. The weight transmission is mainly through tibia. The bone gives attachment to muscles, and as it is not involved in any weight bearing, a piece of this bone can be used as a bone graft. Now, as fibula is another long bone, it is described as upper end, lower end, and shaft. Here we can see the upper end of fibula is expanded and it is called the head of fibula. The pointed upward posterolateral part of the head here is called apex or styloid process of fibula, and the constricted part below the head is called neck of fibula. Superiorly, the head has the articular facet for the attachment with the lateral tibial condyle to form superior tibiofibular joint. And the margin of the facet gives attachment to the capsule of tibiofibular joint. The lower end of fibula is the elongated structure which is completely palpable and is wholly known as lateral malleolus. It extends lower and more posteriorly as compared to medial malleolus. Here you can see that it is zero point 0.5 to 1 centimeter lower than medial malleolus, and posteriorly it extends 1 to 1.5 centimeter. This is the anterior surface of malleolus, and then we have the posterior surface. On the medial surface, anteriorly we have the articular facet for the ankle joint, and posteriorly we have a fossa called malleolar fossa, and the lateral surface is the subcutaneous part. Now describing the shaft of fibula, it is thin and slightly twisted, and it has three borders and three surfaces. Here you can see it starts from the anterior aspect of head and it is extending downwards. In the lower part it is divided into two parts and forms this triangular area just above the lateral malleolus. Then the medial or interosseous border is lying very close to the anterior border, just 1 millimeter distance, and it may not be visible above and below, but it is more prominent in the middle part. We can trace it from the head, and then going downwards it is going to end in the anterior border of the talar facet. The posterior border starts from the styloid process and ends on the posterior aspect of the lateral malleolus. And then these borders enclose three surfaces. The smallest one is the medial surface, which is between anterior and posterior border, you can see here that it is very thin surface. Then we have lateral surface. This is enclosed between the anterior border and posterior border, while the posterior surface is enclosed by posterior border and interosseous border. It is more of a posteromedial surface. You can see here a small part is visible here, and then medially there is this prominent line or prominent border which is visible on the medial posterior surface, that is called medial crest. It divides the posterior surface into two parts, keeping the expanded upper end superiorly, with the stylet process projecting superolaterally, or should I say posteriorly and laterally. Then keeping the lateral malleolus downwards in such a way that the lateral surface is a roughened subcutaneous surface and medial surface has the facet anteriorly and the malleolar fossa posteriorly. This determines the side of fibula. Here in this diagram, it is the fibula of right side. Now looking at this diagram, you can see that most of the muscles of anterior and posterior compartments of leg and the lateral compartment of leg are arising from a fibula mostly. Other than tibialis anterior, the rest of the muscles arising from medial surface of fibula are extensor digitorum longus here in the upper part of medial surface and interosseous membrane. Then you can see extensor hallucis longus arising from the lower part of medial surface and anterior border and the interosseous membrane. And then in the lowermost part of anterior border and medial surface, you can see the fibularis tertius muscle arising from it. From the upper part of lateral surface, we have a region of fibularis longus, and from the lower part of lateral surface, we have fibularis brevis muscle. These both are part of lateral compartment of leg. Posteriorly, we can see other than tibialis posterior and flexor digitorum longus, the muscle arising from fibula are soleus in the upper part from the posterior aspect of head and the posterior part of the lateral part of the posterior surface. Then below that is the origin of flexor hallucis longus muscle, and then fibularis muscle, fibularis brevis muscles origin is extending on this posterior surface as well. On the medial border, there is attachment of interosseous membrane, you can see in this diagram. Other than that, there is capsular attachment on the margin of head facet, and then there is another ligament which is going to form syndesmosis of inferior tibiofibular joint. There are associated ligaments of ankle joints and knee joint, which will be discussed with the joints. As discussed with the tibia, and the head of fibula here you can see is the palpable or subcutaneous part, and then the lateral malleolus is palpable or subcutaneous completely. The palpable parts of bone are usually suitable for taking biopsies. As fibula is not a weight bearing bone, part of it can be used as bone grafts and can be replacing other bones in upper limb and lower limb, where there is removal of bones due to tumor or necrosis and trauma. Fractures can be discussed in the next slide. Fibular fractures are usually associated with tibial fractures, and they are occurring more in the lower part of fibula. Here you can see with the twisting of angle, especially eversion, there is a fibular fracture and also tearing and sprain of ligaments associated. You can also see that in transverse boot top fractures that occurs in skiing people, there is a fibular fracture, and the lower one third of the shaft of fibula is fractured. There can also be overlapping of the fracture along with tibial fracture and shortening of the limb. Then there can also be diagonal fractures and shortening of the limb due to overlapping. A very important relation with the neck of fibula is of the common peroneal nerve. A common peroneal nerve is associated with the neck of fibula, and it can be damaged along with the fracture of neck of fibula, or it can be compressed against the neck of fibula, resulting in foot drop. Then we have another scenario as shown in this diagram, that in case a foot is stuck in a hole in a ground or trapped somewhere, and it is in effort to remove the foot, it is forcibly abducted and everted or externally rotated. In this scenario, there is spiral fracture of lower end of fibula, or you should say lateral malleolus. There is also strain on the medial collateral ligament here, and the medial malleolus can also fracture like in this diagram. Then the lower part of lateral part of the fibula can also tear like here. These are the different stages of an important fracture known as Pott's fracture. Here we have completely discussed the features and attachments of fibula and its clinical anatomy, and you can also check this link for detailed description of this bone. Thank you.